Hello, welcome, and to those of you who don't know me, I'm Dr. Sam Huller. I'm one of the GP partners at Crown Heights, and I'm also the clinical director for the Mosaic PCN. Can I first start by apologising to you, because what I had hoped would be happening was that you would be listening to me in a hotel or similar kind of conference facility where we could all be congregating together to run this particular session. But as I'm sure you've all realised, under the current pandemic circumstances and the rules around social distancing, that's not going to be possible. So what we are doing here today is I'm going to do a video presentation, and then the hope and expectation is that individually you will all be able to look at that and feed back to us, which I will talk to you about in a few minutes from now. So, if I tell you a little bit about the story so far, it goes back to 2015, and at that particular time the partners at Crown Heights were conscious of three things really. The first was that we had realised that at 25 to 26,000 patients strong, we were probably still a little bit too small an organisation for what we thought might be coming ahead for general practice. The second was that we needed to find a solution for our branch surgery, which was at Lichpit, and the third was that if we were going to grow to be more than 30,000, the obvious way to do that was to join forces with another practice, and ideally what we wanted to do was join forces with a practice that was like-minded and that we felt that we could get along with. Hence we then approached the partnership at Odium and asked if it might be possible for us to begin to work together. And that process went on for a couple of years. And then, as many of you will be aware, the government introduced primary care networks. So the obvious thing to do was for our two surgeries to join forces, create our own primary care network, which we called Mosaic. And as you'll see from the slide there, Mosaic was formed. And that was all going quite smoothly. And then, of course, COVID-19 came along, and that has been both disruptive but also a mechanism for engineering some change. And then the question that really arises from there is, so what do we do now? And the purpose of today, as I would have said had we been in a conference facility, or the purpose going forward from this video, is initially for us to share with you who work for us and alongside us, to share with you the vision that we have for the Mosaic PCN. We want to describe why we think that's important to us, and then we want to capture your ideas and feedback. And the idea will be that as you are watching this individually, there will be an opportunity for you all to feed back in small groups, and as a result of that feedback we will then review this process and see whether our shared vision for the future is in line with what you want out of our organisation. Because we very much believe that this is a team game, and that every single one of you who works for one of the two practices, you are all part of the team and you will do an important role within that team, and we want to know what you think, and we want you to help us shape our thinking. So that's what we're hoping to get out of this particular session. So what happened was, approximately a year ago, the partners from Crown Heights and from Odium went away for a weekend to do some strategic planning. We decided that there were some common themes that came out of our discussion. The first that you'll see on the slide there is the challenges around resilience. And for us at Crown Heights, that had been difficulties over the preceding years with recruitment and retention. Less so at Odium, but I think the partners at Odium are conscious of the fact that as a small organisation, you are more vulnerable to any absences in the clinical workforce. Secondly, we are aware of the increased demand from our population and the complexity of managing those patients, many of whom have multiple long-standing chronic diseases. And then I think, and you'll probably all recognise this particular feeling, that we were sort of running to stand still, that the demand made us so busy that it was actually quite difficult to stand back from what we were doing and ask ourselves, could we be doing things differently? And also a recognition that sometimes there is almost a fear of doing things differently, because however difficult you're finding things now, you might change things and realise that you've only made it more difficult for yourselves. So those are the common challenges that we identified, and then from that we started to articulate a vision. So the first part of that vision was that we wanted to be proactive in meeting the needs of different patient groups. Secondly, we wanted to ensure that we had fast and convenient same-day access for our patients, and that they were being seen by the most appropriate person to help them with their particular problem. So we needed to work together as a large multidisciplinary team to make our workload more manageable. And we also wanted to ensure that we brought about consistent processes that ran through the whole organisation. So these were the particular things that we identified as a group that were both the challenges, and from the challenges we then were able to articulate a vision. So there were 4 key objectives that came out of that discussion. As I said initially, we want to build a team of a multidisciplinary team of practitioners. We want to look at how we can reconfigure our same-day access. We want to create a proactive and anticipatory care hub, and we want to continually improve quality across Mosaic, build quality into everything that we are doing. So to touch on the first of those key objectives, building a multidisciplinary team, I'm sure many of you will be aware, because I have spoken to both practices about this, but there are additional roles which have been created, or at least the money has been created to help general practice develop additional roles. What those additional roles are is defined, so you can't go away and simply employ whoever you want to employ on whatever terms you want, but we can start to build quite a varied team. So as you'll see here from the wheel, once upon a time traditional general practice really just involved having a GP, then practices evolved to bring in some practice nurses, but still the majority of patients just saw one or the other. But building on what we get from the additional role scheme, we can now start to add in clinical pharmacists, physicians associates, social prescribers, first contact physiotherapists through the MSK service. The clinical pharmacist can be assisted by a pharmacy technician. We already at Crown Heights are starting to work with a mental health nurse, and for some while now we've been working with a paramedic. So you'll see that the roles, and this is not actually all of the roles that can be included within the additional roles reimbursement scheme, but all of this starts to build a team that can do more than perhaps we could do in traditional general practice with just our GP and our nurse. Secondly, we want to reconfigure the same-day access service, and this is where, to some degree, the COVID-19 pandemic has been rather helpful. Firstly, it's helped us because, certainly at Crown Heights, we've been developing a 2 and 3 week wait for patients to be seen, which in a way serves nobody very well, certainly doesn't serve the patients, and is an ongoing tension for us, and then tends to lead to an increased demand for on-the-day emergency appointments, many of which are not necessarily emergencies, but that is borne out of the fact that patients are reluctant, understandably often, to wait more than 2 weeks to be seen. So COVID-19 allowed us to clear our backlog, and for a few weeks, as I'm sure you may remember, things were unusually quiet in general practice. We've then, on the back of that, been able to build on the total triage model that NHS England has been encouraging us to use. And this, in a nutshell, is the model that we envisage that we would like to move to. We're starting to do this already, but we would like to move to it across both practices and to make it the way that we do business with our patients. So you'll see that the patients make contact. Ideally, they will be making contact by sending us an e-consult, and we think if we push really hard, we can get that to be up to 80% of the contacts patients make. And for those who are unable, because of lack of access to IT or through age, infirmity, etc., those who are not able to can still phone us, and the receptionists will work through an e-consult light with them, filling in a small template that allows them then to put them onto the GP screen with a little bit of history. Well, I say put them onto the GP screen, but in fact what we want to do is move away from the system of everything just going to the GP. So that carousel of clinicians and others working within the organisation that was on the previous slide, that is what we wish to feed into when the work comes into the practice, so that a care coordinator can look at the e-consults and then decide who within the team is the most appropriate person to be dealing with that particular problem. So it may be that if they phone up with a back pain, they can go onto the first contact physiotherapist's screen. It may be that if they phone up with a child with an earache, we can put that in with the physician's associate. It may be that if it's a problem primarily linked with their housing, that we can put them onto the social prescriber, and so on. So what we're trying to do is build a team of people that can deal with this work, but aiming to deal with all the work that comes in on that particular day and avoid a system that we've had of old, which is where when the day's work is full, then people go onto the waiting list and your waiting list grows and you're waiting 2 or 3 weeks to see or speak to a clinician. So that's the second key theme about reconfiguring same-day access. Thirdly, we want to create a proactive and anticipatory care hub, starting to now be referred to as a well-being hub. We already have something of an existing team at Crown Heights. We already have our own community matron. That's someone that we've employed, Lynn Aldridge, as many of you will know. She works for the practice, not for Southern Health, and not in the traditional community matron role. We also have had a small team of paramedics, so we have an existing team that is doing some of the visiting for our frail elderly, most needy patients in the community. But we want to build on that team. We have just recruited a link nurse to join Lynn in her team. We already have a social prescriber, Sarah Elkin, who many of you will know. We are working with a link social worker from Hampshire County Council, and we're in the process of employing a care coordinator to work with this particular team. We are also keen to encourage our community nurses and the palliative care teams attached to our particular locality. We're really encouraging them to see themselves as part of this big team in the anticipatory care hub, and we are proposing to move that to the top floor of Old Basing. We'd like a big visible display in real time with our patients on there. We'd like the ability for the GPs either to visit the hub first thing in the morning by physically arriving there and talking through cases with Lynn and team, or to dial in on Teams, because we've all got so much more used to doing this virtual working. So we're asking that if you have a particular issue, then you can dial in virtually to speak to the team. And then finally, we want to continuously improve the quality through the organisation. And every change that we make, we want to try and ensure that we build in quality. We want to make sure that we are taking into account patient safety, that we're doing performance benchmarking, that we're doing complaints, feedback, all the usual kind of mechanisms to ensure that we've got quality both for ourselves and to make sure that we're providing a good service, but also to satisfy CQC and others who want to know what we're doing and whether what we're doing is safe and caring and effective, etc. So what are the next steps in all of that? Well, the building of the multidisciplinary team I've talked about to some degree. We're interviewing very shortly for pharmacy technician. We have a physician's associate coming in to join us at the beginning of November, and we're hoping to recruit a second person to join her. The first contact physiotherapist has already started, Peter Burns, as some of you will have met, and there will be others being added to that team over the course of the next 12 to 24 months. The reconfiguring of the same-day access service, well, I've talked about how we are moving towards that already, and the next step really is about training some of our team to act as care coordinators to make sure that e-consults are allocated to the most appropriate member of the team. The proactive anticipatory care hub, we're already looking into the mechanics of how we relocate the team to the top floor at Old Basing, and as I mentioned on the previous slide, we have already begun to recruit that team. The last bit about continuously improving quality, we are still in the planning phase for that. We need to define exactly what the roles will be, and we need to recruit at least one individual into that, but I'm confident that that will happen. And then from there we will build a plan for quality improvement across the organisation in the coming years. So that's a bit of a whistle-stop tour through the strategic plan as we see it. I would have said, would you like to ask me any questions? And if you were sitting in the room with me now, you'd be able to ask me those questions. But I would be keen for you to ask questions by sending in an email, and when we give you the links to this particular YouTube video, you'll be given a mechanism by which you can email me directly, and then we will also be making contact with you about how we ensure that there is a feedback session for each and every one of you to give us your comments and thoughts.